Sorry, so we're inviting Kurt Beckwith to make his presentation.
So hopefully I'm not sharing too much, but Blaine and Amanda were lab partners in anatomy lab. Blaine and I did residency together in internal medicine. Now I'm working with Amanda in Washington, D.C. and her colleagues. So it all comes full circle back to the TasP meeting. Thank you, Julio, for bringing us all together. So I'm going to talk a little bit more about criminal justice. I'm not talking about a specific study, but I'm talking generally about criminal justice settings and how do we implement treatment as prevention as well as seek, test, and treat, which I'll use synonymously. So as Shoshana outlined, here's the criminal justice spectrum. There are really good opportunities for testing throughout this spectrum at different points along the criminal justice process. There are certainly opportunities for getting people on ART during periods of incarceration. And importantly, it's very important to remember that people who are out of care in the community, when they come into the criminal justice setting, that's an opportunity to re-engage them in HIV care. So that needs to be well recognized. However, there are definitely potential barriers to implementing treatment as prevention due to the nature of the criminal justice setting, and given that it forcibly removes people from their community, and it may be taking them off of the continuous treatment that they're getting in the community and locking them up. So there are potential barriers for sure. So just to review a few of those, financial are significant barriers for cash-strapped criminal justice systems. Those often flow to the top in terms of problems, in terms of getting things started and implemented over the long term. Competing priorities, the purpose of these facilities is not to provide public health interventions, but it's to detain and provide security. Logistical barriers are significant given the security measures and limited movement of inmates. HIV stigma is clearly an important barrier. Knowing one's HIV status is often a disincentive for them to seek services, as well as testing in that setting. Lack of confidentiality is often a concern with respect to medical records and HIV test results. And then implementation of programs, the way something is implemented in the criminal justice system may have a significant impact on its outcome and its success. And comorbidities, we all know there are very high rates of addiction, viral hepatitis, hepatitis C, we could spend the whole day talking about in criminal justice, tuberculosis in many parts of the world. All of these things make the treatment of HIV in this population much more complex. And then transitions in and out of criminal justice settings affect continuity of care and long-term ART use. And then there are structural barriers which should not be minimized, but when somebody comes out of the criminal justice system, they're dealing with unemployment, with homelessness, poverty, and so forth. So in this talk, I'm just going to focus on two, implementation of programs related to HIV testing, and then transitions in and out of jails and prisons related to treatment and retention. So when we talk about HIV testing in jails and prisons, we need to think about when is it offered? Is it offered when somebody comes into a criminal justice setting? Is there testing available throughout that incarceration? And in some places, it's actually done on the way out from a jail or prison. And perhaps it's a combination of all three, which would probably be ideal. How is it offered? Is it only offered by inmate request, meaning that person needs to ask for an HIV test in the setting where stigma is so significant? Is it only done by physician order? Or are there more broadly reaching routine testing policies in place, either opt-in or opt-out? And then what type of test is used? Is it standard antibody testing, or is rapid testing used, which has significant implications for test result delivery, particularly in jail settings where incarceration times are typically brief and turnover is very high? And then what happens after a positive HIV test? Is confirmatory testing completed? Is there a baseline evaluation of CD4 viral load and perhaps a genotype? And then is there linkage to an HIV provider, both inside as well as in the community once individuals are released? So looking at the implementation of HIV testing, this was very interesting data reported in MMWR, looking at the Washington State prison system. And this, on the y-axis, we have the proportion of prison inmates who were screened for HIV, and then we have time on the x-axis, and you can see there are three different time periods here. In the first one, from 06 to 07, they had HIV testing only by inmate request, and you can see that does not work. Testing does not get requested. About 5% of inmates were actually tested for HIV. But as soon as they move to a routine testing approach, there's a significant jump. The second period there is opt-in testing, but about 70-75% of individuals were tested with that approach, and then you get additional benefit if you go to opt-out screening. So in the last time period in 2010 and onward, about 80–90% of inmates are getting tested for HIV. So this shows you how the approach of the program can either be a barrier to success, such as testing based on inmate request, or a real facilitator for HIV testing with routine testing approaches. For more information on testing in criminal justice settings, I would point you to these guidance documents. One's from the CDC, released in 2009. The other one from UNAIDS, WHO, also, I believe, released in 2009. They're somewhat similar. They both call for routine testing during medical visits within criminal justice settings, but testing should be available at all times during the incarceration. It should be free of coercion. It should protect confidentiality. It should reduce stigma in the way it's implemented. And it should be part of a comprehensive HIV program, so if somebody does test positive, they can get the services they need, including ART, counseling, and then linkage to providers. Now switching to HIV treatment. So treatment in criminal justice facilities can be successful. The figure on the left is from the Bureau of Justice Statistics in 2012, and it looks at the rate of AIDS-related deaths in state prison, which is the top bar, compared to the rate of AIDS deaths in the U.S. general population. And you can see a significant decline in AIDS deaths inside state prisons from 2001 through 2009. In fact, it goes underneath the rate in the U.S. general population. And this needs to be attributed to ART use inside of prisons and successful outcomes related to that. Now, I would give you the caveat that this is typical in prisons, not jails, where jails have high turnover, as I mentioned. But there obviously needs to be access to ART within the context of an existing HIV program. And it's also more typical, if you look at the international literature, of high-income countries to have results like this compared to middle or low-income countries. But I would point out a recent report in PLOS ONE from Davies et al. That looked at treatment outcomes of South African prisoners, and they had very good viral suppression rates, so that's very encouraging. So the successes of HIV treatment on the inside, unfortunately, are often lost on the outside, and Evan was pointing to some of this literature. There are multiple studies showing that viral rebound is common when people are released, and that can be due to a variety of factors, but ART is often discontinued, as the Texas study pointed out, due to loss of benefits, including ADAP enrollment. There can also be relapse to drug and alcohol use, as well as the impact of untreated comorbid mental illness. And then again, the structural barriers are paramount. These often float to the top: homelessness, unemployment, poverty, lack of social supports. Those things are more important to the individual who's getting released than taking their ART medication typically. And actually, Evan also pointed out these great studies, but looking at drug-using cohorts, both here in Vancouver with Malloy et al. And Ryan Westergaard in the ALIVE cohort, both of these studies really show the impact of repeated incarcerations on adherence to ART. In Vancouver, they showed a very strong relationship between the number of incarceration episodes and the odds of being non-adherent to ART. And then with the ALIVE cohort in Baltimore, similarly, they showed recent incarceration was related to lack of attending clinical visits and receiving ART compared to those who did not have recent incarceration. And then finally, I'll leave you with this. I think I showed this last year, but I think it's a very telling slide. This looks at incarceration around the world, and the size of the circle over the country is the incarceration rate for that country. But this is a problem for all of us. If seek, test, treat, treatment as prevention is going to succeed, we really need to bring in criminal justice. It's part of a broader community-wide strategy. There are unique barriers, but those can be overcome with further research, implementation science research. But we also need to partner with our criminal justice institutions, because it's very difficult to do anything inside criminal justice if you're not working directly with them. So I just want to thank the workshop, as well as NIDA and our Center for AIDS Research.